Test 1 2 1 2. Test 1 2 3. Yeah.
Is there any specific direction I need to look at?
You just look around. Usually, there'll be like nobody here, and all of a sudden, somebody starts piling in. Yeah, it usually will start piling in, so you'll just look around. Or you can look in the camera if you want to.
Well, I prefer not. I didn't know if there was a certain angle or.
No, you'll get, most people are probably gonna sit, you'll get a bunch of people right here, most of the pharmacists. Pharmacy people usually sit right here on that row. That's not bad. How long does this last? Okay. Yeah. Oh, that's fine. That's not bad. That's not a bad thing. Not a bad thing at all.
Good afternoon, everyone. My name is Whitney Brown, and I am a family nurse practitioner with Eastern Hospital Medicine here at St. Vincent's East. Today's presentation is a partial fulfillment of my doctoral nursing studies program at Troy University, and I am very happy to be the presenter today. Today's presentation is on the prescription drug monitoring program, also known as the PDMP. Before we go any further, I would like to share with you that I have no financial disclosure or no financial affiliation, and there will be no off-label uses during this presentation. You will receive 1 continuing education credit for attending today, and this presentation is associated with a research study. You are not obligated or required to participate in the research study. However, if you have already agreed to enroll, your participation is appreciated. The misuse of opioids and heroin is one of the most public issues in the U.S. currently. It's been getting a lot of media, and it is an ongoing issue and has been for quite some time. Opioids are killing more people than motor vehicle accidents in America. In 2016, 11.8 million people admitted to misuse of opioids in the last year. 11.5 million of those people admitted to misusing painkillers. Excuse me, 2.1 million people had opioid disorders, and 1.8 million of those people had prescription pain reliever use disorders. In a survey with the Substance Abuse and Mental Health Services Administration, the #1 drug that was being misused was no preference. The second drug was hydrocodone, and the third, oxycodone. Codeine came in at 4th place. In the same survey, in the Substance Abuse Mental Health Service Administration, participants were asked to recall the last drug that they misused and give a reason for the misuse. If they listed more than one reason, they were asked to narrow that down to a specific reason. And as you can see on this slide, 62.3% reported that they misused the pain medication for the relief of physical pain, and the other higher portion at 12.9% was to get high. You can also see at 10.8%, they used it to relax, and a 3.3% used it for sleeping purposes. In this slide, you'll see that the same survey reflected that the source of prescription pain medications that they had for misuse was quite a large percent of diversion, and they were getting that from friends and family. And it did not matter if they bought that from a friend or a family member, or if it was given to them. In this slide, you'll see 2013 state mapping, and it shows on the darker areas of the map, you'll see here, these are mostly southern states. But these states are problem areas. So there has been a steady national increase noted over the last several years, starting around 2006, and that peaked around 2012 and 2013. At that time in 2013, the overall national prescription opioid rate was 81.3 prescriptions per 100 people. Fast forwarding just a few years to 2016, this same map, as you can see, it improved some. All of these states are not as dark, but as you see, Alabama is still a dark state and has been for quite some time. Although the rates are improving, we still have a lot of work to do. In 2017, the overall national rate was 58.7 per 100 people. While this is a success, some counties are 7 times higher. The top 4 states for the highest opioid prescribing rate in the United States in 2016 was Alabama. The next state was Arkansas and Tennessee, with Mississippi following. As you can see, in 2016, the opioid prescription rates per 100 people had declined to 121 per 100 people. However, that's still quite a large amount. Anything above 107.5 is considered a problem area, and a red state on the map that was shown previously. In this map, when we look at the issues by county, it's a little bit more difficult to see what areas are the problem areas. But if you still look at this area here, which is still the southern area, you'll see that there are more darker areas than these. Larger portions over here, but more small, dark areas on the map. And Alabama is still saturated in this mapping. So we'll jump here to the surrounding counties and the prescribing rates for the surrounding counties of the Birmingham area. Walker County ranks number 1 for the surrounding Birmingham counties with 235.4 prescriptions per 100 people. This was in 2016. And the next highest ranking county in our area is Chilton County, prescribing 120.4 per 100 persons. And third goes to Jefferson County, coming in at 116.7 per 100 people. Drug overdose deaths by residents in Alabama in the selected counties. This is over a period of time in 2013 and 2015. Just by looking at the map, Jefferson County is a more metropolitan area compared to Claiborne and Lowndes County, which are rural areas. And based on the findings, there is no socioeconomic barrier. And so essentially the entire state is affected by the opioid issue. If you look at this map, you'll see overdose deaths and Occurrence. Over a period of time, it's continuing to climb. There is no decline, if you notice, just straight across the board. But the sharp increase from 2013 to 2014 was mainly due to heroin-related deaths. And the sharp increase from 2015 to 2016 was in relation to fentanyl-related deaths. Again, prescription abuse has quickly become a public topic in the U.S., and 44 people in the U.S. die from an overdose prescription painkiller a day. Alabama is still the highest, Alabama is the highest opioid prescribing state in 2016, and we're hoping to improve that over time. Diversion is the illegal distribution and abuse of a prescription drug for any reason other than provided by the prescriber. As you can see, there are different types of drug diversion, such as dock shopping, drug theft, and even selling drugs. And there are illegal internet pharmacies. As you all know, you can pretty much get anything off of the internet. According to the U.S. Department of Justice, Title 21 Code Federal Regulation, controlled substance prescriptions must only be issued for legitimate use. So when prescribing, just be mindful that if you're prescribing an opioid, it's not for a tummy ache or something of that nature. Just try to reinforce that with your patients. They may try to negotiate otherwise. In this slide, you'll see that pharmacists reserve the right to contact the prescriber if they become concerned about a prescription due to addiction or a habit that they've noted, safety and health concerns, or requesting, if they are concerned about conflict with the law and concerned about the best interest of the patient. Sometimes patients aren't aware that if they're taking something else, that a painkiller or opioid or something of that nature can cause issues in combination with other medications they're taking. Ultimately, pharmacists reserve the right to exercise their professional judgment when issuing medications or dispensing controlled substances. If they see a red flag and it raises a concern, they essentially have the ability to refuse to dispense that drug if they cannot confirm the validity of the prescription. As providers, how can we make a difference? I want you to be mindful when you're prescribing. The PDMP, the Prescription Drug Monitoring Program, is essentially set up to assist you as well as pharmacists and law enforcement to protect your license and to protect the patients and avoid abuse, diversion, and misuse. So being mindful and checking the PDMP before you prescribe is essentially a great resource to assist with your care. You want to make sure that you're dispensing appropriate quantities, and you want to set management goals so that you can manage the expectations of the patient. Also, you only want to prescribe opioids when the benefit outweighs the risk. The PDMP was established to improve clinical decision-making and increase detection of drug abuse or diversion, and also increase access of controlled substance history with the patient and the prescriber. It's also a tool to increase surveillance by pharmacists. Your pharmacist can be your best friend. They may see something that you have not had time to look at today because you've seen so many patients, and they say, wait, this patient has come in several times for multiple prescriptions, and this doesn't look like something that this provider would write. They could, alarm you of that and make you aware and help address the situation before it gets out of control. Addiction is expensive. As you can see here on this chart, the overall cost of substance abuse in 2013 was $78.5 billion, and $26 billion of that cost was contributed by prescription opioid abuse. Although the prescription opioids are not the highest on that list, it is a major concern, and if we don't get control of it soon, it may be. Now we're going to discuss the Prescription Drug Monitoring Program utilization. Some of you may be asking, what is the PDMP? The PDMP is essentially a surveillance tool that is used to monitor medications that are prescribed under the care, when patients are under your care. And it is controlled by the Alabama Department of Public Health for Alabama, but each state is different. It is essentially used to monitor the activity of controlled substances. And again, the purpose of the PDMP is to assist pharmacists and providers with the means to monitor patient usage of controlled substances, reducing prescription rates or prescription abuse by providers and patients, and reducing law enforcement's time being spent exploring leads. It's also used to educate providers, law enforcement, pharmacists, and the public with the data that is collected to make improvements. Features of the PDMP. Law enforcement can request a PDMP report at any time. However, due to new changes, in order for law enforcement to request a query of your PDMP report, there has to be a notarized document stating that they have declared probable cause. The regulatory board can check your PDMP licensure history with this, and that, again, is the Alabama Department of Public Health. There are multiple things and multiple benefits of the PDMP. You can search your own activity, and if providers have a mid-level, whether it be a PA, midwife, nurse practitioner, you can also search that activity and check the morphine milligram equivalent. Only physicians are allowed to have a delegate, but physicians can have up to 3 delegates if one of those delegates is a nurse practitioner. If one is not a nurse practitioner, they are only limited to 2, but the delegate does not have to be a licensed provider. It can be your office manager or someone of that nature, but they do have to be registered. You can also check the activity of yourselves and perform a self-audit. And if you'd like to hear more about how to perform that self-audit, you can see me after the presentation. I'll be more than happy to assist you with that one-on-one if you would like. And I also encourage you to do that frequently. Sometimes DEA numbers can be entered incorrectly, or sometimes providers have a common name, and so again, to err is human. It's just a good thing to keep track of. There are reporting requirements. However, veterinarians are exempt from reporting, as well as methadone clinics. That is a federal law, and the reason for that is they're just covered by the federal law. But if they do prescribe a methadone prescription and it is filled at a pharmacy and not given in the actual clinic, that will show on the query, just so that you're aware. Who has access to the PDMP? Any certifying board has access to monitor, and as well as licensed pharmacists. State licensed practitioners with a quality Alabama controlled substance certificate, they have that option. PAs, NPs, midwives, etc., and MDs, optometrists, veterinarians, and dentists. The DEA indirectly, again, has access to it because they have to request that. But Medicaid agencies have access as well, but only for patients that have Medicaid. Physician delegates, again, also have access, but they have to be linked to the account. So if you do have a delegate that you are interested in getting registered, you'll do so by going through the Alabama Department of Public Health with the PDMP. Once they register, you just need to make sure that they don't register as a physician, as if they're trying to register under you. They'll need to specifically select delegate as their license type. And then once they are approved by that department, they will link the account. They can't see anything until that account is linked. All dispensers of controlled substances are required to report to the PDMP, again, except for methadone clinics and federal facilities, as well as veterinarians. So the dispensers, again, include the pharmacist, the physician, other practitioners who are licensed with a regulatory board. So if you give a patient a prescription and it goes out of the door with them, or it goes to them, that is considered prescribing a controlled substance. So that person would be responsible for checking the PDMP unless the person is in a hospital setting. So if you're a hospitalist and you are prescribing during the day, it's not necessary for you to check the PDMP at that time. However, if you prescribe discharge medications and those happen to be controlled substances or opioids, then you do need to do so. When logged into the database, there is a 15-minute delay. Some of you have cookies or you've saved it under your Google Smart Lock on your computer or something of that nature, and that's fine. Just make sure that when you are done with that you do log out, because this is a safety mechanism. Also recently, the PDMP has moved to a new program known as Occurrence, and so data was deleted. So if you are to search now, you can access up to 2013 as far back for those records when you're querying the PDMP. And please remember that the data is only as good as the person entering it, so another reason why I suggest that you do a self-audit. Only the person who entered that information can make corrections. So if you do find after you do a self-audit that there is some inconsistency, maybe your DEA number has been entered and it wasn't supposed to be under your name, or the patient didn't belong to you, something of that nature, at that point you can contact the dispensing pharmacy to request that correction. If you have any issues with that, you can also contact the Alabama Board of Pharmacy. And if you find that you have prescribed a controlled substance and the pharmacy is not reporting that, it may be an error. The pharmacist may not be aware that they're entering the information in wrong, or they may not be aware that it's not showing up. So you can also contact the Alabama Department of Public Health, PDMP, and they can assist you with that. They can contact that pharmacy and make sure that they are aware that they are supposed to do this, and if they have any questions at that time, they can help them with that. So using the system, when you search, you essentially want to make sure that the search is as narrow as possible. That ensures that you don't have to wait so long for the query to come up. And so if you put in all genders and avoid putting anything in the zip code, for example, if you enter someone's zip code for Hoover, Alabama, and they happen to live in Vestavia, it won't show up. So you want to leave that blank so that you can search to the best of your ability and find what it is you're actually looking for. You can also use social security numbers to help with the search, especially if the patient, for example, got married and is now using their married name, but when you saw them last, it was their maiden name. You can search by using their social security number. And if they have a hyphenated name, you can go under alias and type in 2 last names to specify the search. There was an option for multiple state searches, but that will also slow down your query. So just a reminder, if you have a collaborating physician and you are a nurse practitioner or a PA or a midwife who is actually prescribing, if you do change locations or practices, you need to make the Alabama Department of Public Health aware, because they have no control over that. They don't necessarily communicate with the boards on the collaboration agreement, but you need to make sure that that's updated so that it's not attached and that account can be unlinked. So the new system is called Occurrence, and now if you have not logged in recently with the launch in the last year, the username is now your email address. There's also a webinar, an intro webinar on the left-hand column once you log in, so that you can utilize that as a resource if you're not familiar with the actual program. There are also some other helpful resources in there that you may be able to use in your office or with your patients when discussing opioid prescriptions or opioid addiction. So quarterly, it began in April of 2018, a quarterly prescribing report is issued, and some of you may have recently received that in August, but the report essentially goes out to compare any behavior or red flag indicators with high-risk behavior or combo therapy or treatment duration. And that ranks you among your peers. So essentially, if you are a ED doc, then it's going to rank you among emergency room prescribers as opposed to dentists. So what can I do to decrease the numbers in the opioid crisis? A few things that you can do. You can check the PDMP to improve safety and decrease opioid misuse and abuse and overdoses. You want to also discuss with your patients respiratory depression and consider issuing naloxone prescriptions for those if that patient is taking 50 morphine milligram equivalents a day or more. And you also want to discuss a plan to taper and discontinue the opioids when appropriate. And by appropriate, I mean initially it's best to do that when you begin them on that medication. If they're already on that medication, then of course you want to use your clinical judgment and see what the ultimate goal is and how far you are, because you want to help the patient see what the end goal is, and so that they're on the same page as you. Sometimes it's a little easier to get them to cooperate. You also want to discuss checking the PDMP regularly with the patient. Make them aware that this is a resource that is provided to pharmacists and providers, so that they are aware that you can check it at any time, and hopefully that gives or holds them accountable for their actions as well. And you also want to avoid concurrent prescriptions of opioids and benzodiazepines as much as possible. Obviously, that's not always possible, but you want to communicate with other prescribers so that you're all on the same page and weigh the risk. So if you are not familiar with how to access the Prescription Drug Monitoring Program or the PDMP, you can go to the website www.alabamapublichealth.org/PDMP and log in. And if you need assistance with that once you're in, you can contact this number. And once it picks up, you can click option 1 if you are a prescriber. And if you are a pharmacist, you can select option 2. So the home page essentially looks like this, and as you see here, they've actually changed the website, and so it used to be .org, it's now .gov, but you see here on the left-hand corner, right here, you'll just select prescription drugs, and it will take you to the next page. And here you'll select PDMP login. The login page looks very much like this, and again, your username is going to be your email address. So when querying the PDMP, there are requirements, and failure to do these may deem that you have violated some law. But the requirements for utilizing the PDMP are as follows. If you prescribe 30 MMEs or less, you can check that, 30 MMEs or less a day, you can check the PDMP periodically. But if you prescribe more than 30 but less than 90, you need to check that at least twice a year and document that in the medical record when you do so. If you prescribe 90 or more cumulative prescriptions a day, then you need to use the PDMP each time that you prescribe and document the use in the medical records as well. Those who are exempt from using this would be if you prescribe to a nursing home patient. That prescription doesn't have to be checked using the PDMP, or if you're seeing a hospice patient and you prescribe for the hospice patient, as long as you put hospice on the actual prescription, that is also exempt from PDMP checking. Oops. And if you are treating active cancer, then you do not have to use that prescription check for the PDMP. But that's only active cancer and malignant pain. But if there is someone with chronic issue with cancer or chronic pain or chronic cancer pain, and that's non-acute, you need to make sure that you do check that, as well as you need to check for intraoperative care. So if you are in a hospital setting, again, you do not have to check for the treatment that you're prescribing in the hospital, but once that patient becomes discharge worthy and you prescribe an opioid or a controlled substance to go home on, then you do need to check the PDMP. And that concludes my presentation for today. And I'd like to give a special thanks to Nancy Bishop for also sharing the data resources to assist me with this presentation. And thank you for your time.
You did good. Just in time, I think the battery's about to go down there. See a little clip up there? Just pinch it and it'll drop right off. Thank you very much. Oh, if they did, they'll come up to you afterwards. You're fine.